Well, it's a Monday, and it's back to podcast time here on Beyond Clean with Ace, where the cleaning industry talks. You know what? We talk all the time about cleaning. And no, we don't only talk about cleaning. It's why it's called Beyond Clean with Ace. And so, hey, earlier this morning, I was talking with a bunch of people about indoor air quality. This afternoon, well, I'm not talking about indoor air quality as such. But there's studies that come out all the time, and we all hear them, we all see them. But it's very rarely that we actually get somebody on the air with us that actually was involved in the study and can talk to us about really what it all says. The stuff behind what is written on the paper. And this afternoon, well, I've got that person with me. So if technology works right and everything, he should be here on the line. Let's see if it all works right. Brian, I like to see your face and your smile. Is there a voice that goes along with that?
Good afternoon, Dave. Thanks for having me. Yes, sir, there is. Yes, sir.
Oh, okay. And so I'm in Florida. Where are you at today, Brian?
So I'm actually talking to you two from my home office, which is in New Jersey.
Jersey. Okay. Well, you're a little north. Hey, at least we're both in the same time zone this time.
That's right. Yeah. I'm the area vice president for EvaClean infection prevention. I'm the acute care lead as well, and I run the East Coast from Maine to Florida, handling all the healthcare.
All right. So
although I'm here today, I may not be here tomorrow. With such a huge territory and for client support, I'm quite a bit, spend a lot of time on planes.
Aha. So that's why I asked today, where are you? Because I had no idea, as we're now being able to travel and go to these places, but you spent the last nearly 2 years in COVID in a hospital. Come on, man.
Yeah. It's been, look, what we've seen, unprecedented times. I don't have to tell you, Dave, it's been unbelievable to see the resolve of these folks, these frontline, and having, being in there with them, by no means, what I was doing was, just monitoring and assisting where I can. But, I don't have to say it, these frontline workers, these nurses, these doctors, all healthcare professionals, just what we've witnessed in the last going on 3 years now, which is incredible too, has just been sort of remarkable. So yeah, we've had some challenging times as of late, but hopefully we're starting to see the light at the end of the tunnel, and we're looking forward to moving on from this, as everybody else is.
I think it's interesting, as I was looking at the study that you provided to me, that at first I just was looking at the study and what it all said, and we'll get to that, folks, here in just a minute. But then I thought, you're doing this during a very trying, very pressure-packed time. That had to add a whole nother level to this.
Dave, it was amazing. And right, what better way to get an accurate depiction of what it is we do than in increased times like this? Yeah, it was this NYU study spearheaded by Dr. Phillips was spoken about for a while. His clinical team up at NYU main campus been working on it for the last 16 months. So it was very, very challenging. But in the same breath, we really got to see it true and true, so it's not just a small sample size. The results were so unbelievable, but we're unfortunate, but fortunate enough to have it through a time where it was needed the most. And it was very, 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 very trying.
So folks, what we're talking about here is a study with NYU, and Brian's going to get into the nuts and bolts of this, but I've been doing this for a lot of years, and I've been in and out of hospitals, and we try this, we try that, but you had to probably really do some pre-work to actually get this all set up, let alone the last 16 months. This had to be like a year in advance of getting this ready. Yeah.
So they, the forward-thinking staff over at NYU really did the pre-study work. Identifying what it is with similar claims that we have with our chemistry, and really giving it to what they wanted to see as it relates to chemistry, what they wanted included in the study.
Mm-hmm.
So yeah, all that took quite some time prior to the start date. And another thing too, so not only was the study done, and what the study was that was complete was they put our chemistry, NADCC, against multiple other chemistries. And it was judged on how it performed as it relates to, killing pathogens and really the reduction of HAIs within the buildings.
Okay, so now wait a minute, hold it.
Sure.
Wait a minute.
Sure.
You used an acronym there for the first time. I knew you was going to do that, Brian. We got people that listen to the podcast that might not know what an HAI is. So let's give them a little bit of what is, not just what the acronym stands for, but really what does this mean?
So what a hospital-acquired infection is something that's, once you're in, say you go for you're going for a thoracic surgery or even a knee replacement, something very simple. If you become infected inside the hospital, that's considered a hospital-acquired infection. There's a number of different pathogens, number of different, fungus and bacteria that you're susceptible to. And if you're diagnosed with that and become infected, that is what we call a hospital-acquired infection. So it's something that is, that is transmitted once in the hospital.
Now, and I understand this, folks, because 2 years ago I went through heart surgery, and that was one of my biggest concern. It wasn't the doctors and the heart surgery; it's what I could catch while I was in the hospital that had nothing to do with the heart surgery that I was there for.
Yeah.
So, I was very curious about that, and I won't go into all of that, folks. Listen to one of my other podcasts; you can hear all about what I did. But
yeah,
this is extremely important whenever you're doing one of these tests, is it not?
Yeah, so it's very, very important. Look, the hospital's such an unbelievable, unique situation. You're bringing the most, the sickest people into an environment where there are compromised people. And in the middle, there has to be a divide. And that divide is the chemistry in which they use to ensure safety, not only of the patient safety, but also the employees as well. So yeah, no, it's challenging. Hospital-acquired infections are, especially now, because up to about 8 years ago, if you were become infected in a hospital, they used to just turn around and really, the insurance company would pay for that infected patient. So, but now the World Health Organization, WHO, really said, you know what, we're going to stop that, because now the onus is on the facility, because, hey, why are we paying if they're infected in you? Just to kind of give you an example of the cost associated with an infection, if you're infected in the hospital, in a county hospital, in a rural area, one infection could equate to about $30,000, $30,000 to $35,000. So the financial implications of becoming infected in that. So that's why these healthcare facilities, NYU, a lot of these big time healthcare facilities, everything is now forward. They're trying to prevent, really prevent this. And that's the precipice of the study. How could we stop the bleeding? How could we increase patient safety? And how do we keep our employees safe? So that was the reason why the study was started about 16 months ago.
I like one of the things, and there's probably several things that you probably heard, folks, that Brian just said, but I key on certain things, and that was keep the technician that was doing the job safe. That is so much of the time something that people don't think about.
Yeah, it's amazing. Our the EVS techs that we work with all over the world really have such an important job. So, the nursing, obviously, to be able to administer what's needed, but in order to really keep people safe and keeping those doctors and nurses and the patients safe too. EVS crew, EVS technician has a very, very mission critical job in doing his work on day to day. So it's very, and we can't share this enough with them. All the folks that we work with on the EVS side of the coin, of how important their job is in keeping people safe.
They had to be a little standoffish about having somebody watching all the time, always in there doing surveys and stuff. I worked with a lot of EVS people all around the country, and I know how. They're not too excited about that kind of, Brian.
Right, Dave, and that's exactly it. So people change in general scare the wits out of people, and I get it. Yeah, change is tough, but once we really, and we have a wonderful clinical team. Not only just it's a true partnership. So we got our clinical team involved. The gal in my territory, Nicole Slasik, really does a really fantastic job with explaining to them. If you just throw it at someone, they're going to reject it. But if they really understand the chemistry, how simple it is and how safe it is and the ability to protect them, they fall in love with it. So it breaks down that, I hate to say the buyer-seller animosity, but it really, if they're educated, if the EVS techs are educated on what they're doing and how much safer it is, it's non-carcinogenic, it's not cancer causing. If they understand that, they'll accept the change with a lot easier. And we do a great job through our education program to ensure that.
And you're right about that, because so much of the time they're hit with these chemicals in different chemistry that while it may look good and kill all this stuff, it's like, yeah, and it's killing me too.
Right. Yeah. No, that's it. And that's, we see that all over the country. There a lot of people now, we hear sustainability is a big buzzword, but
right.
As it relates to, but now these people, the technicians, they're being more educated on safety and their own safety and patient safety. So we do a big part, our education component of our Pure Excellence program really. So it's not only are we training, we don't want the EVS tech to speak clinically about our chemistry, but we want them to be able to communicate effectively to the patients, because they're the ones in the rooms every day with these folks. So we educate them.
Yeah.
So and that's what it is, Dave. I'm sorry to interrupt you, but that's what one thing that we are good at, aside from our efficacy, being unchallenged, is we really wanted to find a difference from what we do compared to other folks. So, and we identified that. Our senior thought leaders, Mr. Richard Prince, who you were fortunate enough to meet, great fellow, yes. Smart, high-level guy, our CEO, Steve Wilson, even our founder, RJ Valentine, they really kind of stepped back and took a snapshot of the industry and trying to identify deficiency of what others are doing. And that's why we came up with such a robust program. And the results have just been amazing. Paired with our efficacy, it's lights out, truly.
Well, and I think that's what we do here at the Academy. We always are talking about the practices that we use. And one of the things that I always teach is that this is a process. It's not cleaning. It's not disinfecting. It's a process. That process requires a technician that is knowledgeable. And I think that's what you're talking to.
Absolutely. Yeah, no, we try to, like I said, a big portion of what we do is education. The chemistry, I could tell you we have one of the first companies in the world with a biofilm kill claim, which is great, but our education component paired with that stuff is second to none. I get constantly, it's so funny. I get asked, we do trade shows. I was just overseas in Amsterdam. We did a huge trade show there, and people come up to me the same thing, Dave. They say, how does this little boutique firm in Braintree, Massachusetts, how does their client roster read the who's who, but it's just by that. So it's identifying what other firms aren't doing and doing that stuff well, because we know our chemistry is unmatched, and that's proven by the NYU study.
Well, speaking of chemistry in the study, one of the things I noticed is said sporicidal disinfectant. So talk to the audience about, somebody reading that may not even really, and I'm sure this was part of the education, there's differences.
Yeah, so our sporicidal is, we utilize, we have two products with the same base chemistry, Pure 1 and Pure Tab. Both the same chemistry. The difference between the Pure Tab and the Pure 1 product is the Pure 1, it has a surfactant in it, so it's a soap. There's a soap mixed in. So not only are you clean, but you're being proactive in disinfecting. And Dave, our chemistry, we're lucky enough to have a pH of between 6 to 7.5, which is the same pH as our skin. So you're going to get, it could be used on many, many different surfaces and have unbelievable results. The sporicidal, you get those claims with C. diff, C. auris, and like I said, the biofilm kill claim, which we're very, very proud. Also,
Okay, right. I got to stop you there. You're back to giving out acronyms again.
Okay.
People are not going to know what this means. So wait a minute. Hold it, folks. I got to go back on this.
I get excited. I told you I'm a talker, Dave.
Yeah, that's okay. And that's what's great. But the thing here is you got several things going on here. One of them is I always teach in classes, the thing that you have to know is that your blood that runs through your veins is 7.365. That's the pH of your blood. Why do you want to put your body and expose it to anything higher than that? I mean, why are we putting our bodies in exposure to 12 pH disinfectants?
Thank you.
Gee, Brian didn't have anything to say to that. Just okay.
No, I tell this story. I tell this story daily, and so not only, but again, also like the high pH on because it becomes corrosive. That neutral pH that we have, non-caustic, non-corrosive, really helps, and that's why we have the ability to use it on many different surfaces.
Okay, now you also talked about C. diff. Explain.
So C. diff is a bacteria. It's a hospital-acquired infection. It's a very it spreads very quick.
Right.
If the hospital-acquired the bacteria, it spreads very quick. Also, there's a pretty substantial mortality rate associated with it. So very rare.
Now, folks, I got to tell you, Brian's being very polite in what he's saying. So I'm going to jump in and say what Brian's not. Folks, Clostridium difficile, which is C. diff, is when you lose control of your bowels. And we mean total and complete control. So if you think that you've had to clean up something, I will tell you, if you've never cleaned up anything, you just don't want to clean them up after a C. diff accident.
Yeah, you put it nicely. Yeah, it's very dangerous. It's very transmissible, and like I said, not just one person on the unit will get it. Multiple cases. So it's very important to identify it, one, and isolate, and then clean using a sporicidal Pure 1. Yeah, it's very
prolific.
Yeah, and 1 in 11. Here's an amazing fact, and unfortunately we see it, and 1 in 11 people over the age of 65 that get it pass away from it. So it's very dangerous. And if you do have it, if you have C. diff, you're diagnosed, you beat it, the probability of you getting it again within 6 weeks, if hospitalized, is 80%. So if it doesn't get you the first time, that's why a perfect, an optimal cleaning plan and disinfecting strategy and program is mission critical. So that's C. diff.
Now, and the reason that we're talking this way, Brian, is because that process of doing both steps, and then we'll follow with another one a little bit later here as we talk, but this is not the spray and pray. This is not something that you can do this. Now, folks, you got to understand, as Brian's saying, C. diff is not something you typically would have had at home. You catch that at the hospital. I know a lady that went in for an eye infection and they had to do surgery and caught C. diff, and 4 months later died.
Yeah. Unfortunately, we see it way too often, and there's a lot of, and yeah, I mean it's we see,
and it usually goes home.
Yeah, and that's what I'm saying. The infection rate, how quick it transfers and how transmissible it is just, it's really scary. That's all
another one there. What was the other one?
Seoris. Now,
Okay.
Seoris is different in that it's a fungus. But the difference with Seoris is it's multi-drug resistant.
There you go.
So there are very few chemistries on the market that have a Seoris kill claim. Pure 1 has a Seoris kill claim.
Okay, so let's review, folks, a little bit. We're talking the right pH. We're talking it can now combat 2 of the different, very prolific, very viral. Mortality rates are high with both of these.
Awfully high.
They now currently, I don't remember on Seoris. Can you re-get that? I can't remember on that one.
I'm sorry.
If you're diagnosed and you get over it, does it come back like C. diff?
It does not. But
I did not think so.
Yeah, the thing is with the mortality rate associated with C. auris is much higher. Unfortunately, it's 1 in 4, and again, it's so transmissible. But what's interesting about both of these pathogens, one being a bacteria, one fungus,
right,
is the C. auris is multi-drug resistant. We know it's a lot harder to kill than C. diff. So you have to make sure a disinfectant that you're utilizing has the C. auris claim. But what's really interesting about both of these pathogens is that they can live in biofilm.
Oh, now we're talking. Hey, I got to tell you, my professor down in Australia would just love to hear you talking about biofilms. Every time I get Professor Whiteley on here, I guarantee you, he goes into biofilms and it's like, you know what? I feel like I'm not doing anything.
Right. Well, here's the thing. So those two dangerous pathogens that both Pure One will kill lie a lot. 65% of the hospital-acquired infections live in what they call biofilm. And what biofilm is, not to get too clinical, it's a bunch of pathogens that form a protective coating over them that is also multi-drug resistant. Just to kind of give you an example, 2 doses of bleach at 10,000 parts per million, 2 doses doesn't have the ability to kill biofilm. What biofilm is very, very hard to kill. And what we are the first chemistry in the world, Pure One is, with a biofilm kill claim. So it was very, very exciting for us that not only we can, identify it, but kill it as well. So that'll eliminate a good chance. And it was just said at conference, if your current disinfectant program doesn't kill biofilm, you're not disinfecting. And it's the truth. But we do a lot of work too with our professional sports leagues, professional sports teams. We're seeing biofilm, we're finding biofilm there in our higher education program. So these, although, they're hospital-acquired infections, the, C. auris unlikely, but other pathogens, COVID or, any norovirus can live in biofilm. So that's why it's very mission critical to have a disinfectant program that can eliminate biofilm as well.
Well, pretty much any virus can live in a biofilm, and I won't tell you that bacteria doesn't, because it does too. It's just not as prevalent because biofilm's going to be more surface. Viruses go deeper, and it's simply because of the size of the microbe. That's
right. That's exactly correct. Yeah. And both, look,
we're splitting hairs here, aren't we?
Those are the most common, but luckily, and the reason why we've gained success and we've been standardized throughout many hospital partners all out the world is because of our claims. Like I said, C. auris, C. diff, and our biofilm claim has been such a huge advantage for us.
Now you actually, when you were in a hospital and you're talking this level of efficacy, you had to get into log reductions, which most people out here in the public that are listening to the podcast today probably aren't concerned about log reductions like you would have been there during the study.
Yeah, it's very, look, our log reduction, we train, a lot of our claims are less than 4 minutes, but because we're in the healthcare, we train to the Joint Commission standards. So we're Joint Commission's compliant as it relates to dwell times. So a lot of times our claims are a lot quicker than 4 minutes, but in order just to maintain compliant with Joint Commissions, we treat that to a 4-minute dwell time. 99.9% of the pathogens on the surface will die after utilizing Pure One at a 4-minute claim. So it's pretty substantial, about 5 to 1. So it's great.
So folks, the reason that we're talking this way is because, there's different places that people in our environment, I was just talking with some people on previous cast here, in a school, and that's not going to be at the same level that you're talking about here, Brian, but there's different log reductions. So what I know what I would say, correct me if I'm wrong, Brian, but a 5 log reduction would be 99.999%. It's how many nines are there.
Right.
Correct?
That's correct. Yeah.
So you might have a disinfectant that was a 4 log, 5 log, or 6 log, but it has to at least be a 4-log to be qualified as a disinfectant. Is that correct?
That's absolutely correct. Yes, sir.
Okay,
Yep.
so you were probably going over into the 6-log, I would imagine.
Yeah, without a doubt. Yeah, so the all the PCR testing and everything that's been done, the swabs and everything, that's all included on the study. And I think you have a link for that that your end users or your listeners can log on to see definitive results. But yeah, how our chemistry performed compared to anything else, with the other chemistries listed in the study there, have been nothing short of just unbelievable, truly. With regards to reduction, we have case studies that we have facilities that have been in process with us that haven't had a C. diff case associated with DVS in over a year. So it's pretty substantial as it costs to the 5-log, 6-log. The reduction of the pathogens that are dangerous have been they're just unbelievable utilizing a pure one.
Well, I talk about all the time that there are levels of what I would call uses of a facility. You're not going to clean the lobby of the admissions room at a school at the same level you're going to clean an OR room,
right?
Simply because of protocols and requirements and all of that kind of thing. So, I think this warrants the conversation that we're having here. Thank you, Brian, because people need to understand that this test was not done under just everyday circumstances in the everyday world. Now, everyday is for NYU, maybe,
right,
but not for us out here in the general public. So why are we talking about this outside of hospitals?
Yeah, that's a great question. Just to kind of show you, so what NADC, what our chemistry is, and great segue. What our chemistry is, NADCC, once diluted with water, creates HOCl, Dave. And as we know, if your listeners don't know, I know because I'm in healthcare. You know because you have Dave. But what HOCl is when we're feeling sick, when we're run down, if a flu of influenza pathogen in our body, we feel a cold. What our own immune system, our white blood cells create HOCl to attack the pathogens in our body.
Correct.
So our chemists came up with a way, years and years ago to replicate that.
Right.
As far as being safe, it's arguably the most safest out there. But the reason why we have the ability outside the healthcare is it's so diverse. We actually sent 3 million tablets over to the Ukraine to make non-potable water drinkable. So you could treat river water with it to make it drinkable, just to kind of show you how diverse. A lot of we are currently responsible for 88,000 classrooms for the New York City Department of Education. They're utilizing our stuff. So it's safe in kids areas. Something that we're real fans about, and we're really, really proud of our chemistry, our pure tab chemistry, is we utilize it through electrostatic sprayer. There are about 11 chemistries in the country that have the EPA registration to be utilized through electrostatic sprayer. Our chemistry is the only chemistry with the 0 reentry. Most other chemistries got to wait 15, half hour, 40 minutes once sprayed to go in. So that just kind of shows you. So not only, and getting back to your initial question, not only can it be outside of a healthcare department or a healthcare environment, it could be used to clean terminal rooms. It could be used to treat drinking water. A lot of our professional sports teams that we work with utilize our Pure One in their wash. They wash their uniforms with it because they're surfactant. So it's so diverse. We even have the ability to use it as a non-rinse in a food at a lower ppm, of course, but a non-rinse for on a food prep area. And
okay, so there's another acronym, ppm. Come on.
Parts per million. Yeah.
Parts per million. Yeah, folks, I'm sorry. It's a podcast. I just got to make sure that you understand all these acronyms because you know what? And this is what's interesting, Brian, is people think that we're talking cleaning and we just don't know. But you hear this discussion that we're having here. This is high level stuff. if you don't know these acronyms and you don't have the knowledge to go with this, you're just going to treat this like something you bought off the shelf at Walmart.
Yeah, it's very important. And because we're tablet form, the yeast, you make a dilution. We have usage guides, but yeah, our ability, it's so diverse. Treat drinking water terminally clean. We use it to clean glass mirrors. It can be used. Like I said, we're vertical agnostic, Dave, which is really exciting. So it's not just pigeonholed into the healthcare. We do a lot with higher education. We do a lot with professional sports teams, with their medical staff, as well as their training rooms. So yeah, it's such a diverse product.
Okay, so you mentioned something about electrostatic sprayers. I want to talk about getting back to our technicians, because that's where my heart is. I'm sorry, that's where my heart is. I'm those frontline people. I mean, application technologies have changed, and folks, I got to tell you, we were talking indoor air quality on another podcast before I got on with you, Brian, and it rings true. Why are we taking a trigger sprayer, putting chemistry in it, and spraying it in the air where the technician breathes it? And they were asking me, well, what's the right application method? So I guess I'm going to go to you. You were involved in the 16-month study.
Yeah.
What kind of application did you guys do that's so unique that the whole world doesn't know about?
Yeah, so we utilized our dry wipe program for the step one, which was the high touch areas. And then what we did in the pandemic, we introduced the electrostatic technology. So that's touchless disinfectant. And if you're not familiar with what electrostatic technology is, it's a spray gun that's loaded with our chemistry. Yeah, you'll see it here on the screen. Thanks, Dave. And what it does, it positively omits 60 microns of fluid to get that 360-degree wrap. That's it in that sprayer there on the left. What's the difference between that and a trigger sprayer is once the spray comes out of the electrostatic, it's positively charged. So anything with a negative or neutral any hard surface with a negative or neutral attractant, it's going to get that complete 360-degree wrap on it. So it's very, very easy to use. And like I said, if you're utilizing our Pure Tab product, which is not the surfactant in it, using it in a trigger bottle, there's zero reentry. It wouldn't be harmful. But with the electrostatic sprayer, you get that complete 360 wrap, and it falls 70 times faster than gravity. So it's going to get to where it's got to go real quick. So
and that's what I tell people all the time. They say it's a sprayer. I said, yes, but you don't understand. It's usually our surfaces that we're working on are negatively charged. The product comes out, whatever chemistry comes out through that sprayer is negatively or positively charged. So it makes the two attract instead of that atomize that just goes all over and floats everywhere uncontrollably. So this is a more direct application.
Yes.
Now, my question to you, and this is something I teach here. I don't know what you did. I didn't read everything in the study. I haven't looked at all the details. But why, I can't understand why, if this is good for disinfectant, why people aren't using this with the cleaner that is part of the whole process. Why not apply the cleaner through this same apparatus and then do the wiping and then apply the, is this,
that's a great question. We have some folks that utilize our Pure One, the cleaner. That's, so the difference between the Pure One, Pure Tab, Pure One has a surfactant, so it's a cleaning agent as well as a disinfectant. But if you put that through an electrostatic sprayer, because it has that surfactant in the soap, it could foam up and become a little bit of a science project. But it's the same base chemistry. So yeah, what mostly people do with the high touch Pure One is they'll go around with the microfiber or one of our wipes, and then they'll follow it up with the step 2 disinfectant utilizing the electrostatic technology. But Dave, another point I want to make to your listeners too, is the difference, because I get it a lot. They said, oh, that's a fogger. I'm like, it's not a fogger, it's an electrostatic sprayer. The difference between the two, the electrostatic sprayer, like I said, positively charged 70 times faster than gravity. It's going to get to where it's got to go. We do not rely on the atmosphere or the environment to get our product to where we need to go. Where a fogger, you go, you set it off in the room. It relies on air current, relies on whatever it is in the room to get it to that surface. So it's a lot more calculated. And so the two can't be, they're so different. Everybody confuses that. I just wanted to be clear with that.
Well, and I appreciate that too, Brian, because I was on with another gentleman and we were talking about mold. This is his business is mold remediation. And he was talking about electrostatic spraying that they come back. And he showed me something I wasn't aware of. And it is a fogger that has now been retrofitted with electrostatic spraying. And I was unaware that they've actually brought the two together in this unit. So I'm like, okay, hey, I learn something every day.
Right. Once that fogger has the electrostatic, we've seen a node because people know. And before the 11 chemistries that were chosen, that were given the authorization to be utilized through a sprayer, electrostatic sprayer, people were relying on foggers. But once that transition occurred, they're only to be able to use because it gets to where it's got to go. So they buy an attachment for their fogger. But once that fogger has an attachment on it, it's an electrostatic sprayer.
Right. And so, folks, I think what you're learning here in our discussion this afternoon is that it's not just one thing. I think that's the beauty of what I saw in this study, Brian, is it isn't just one thing. It wasn't just a chemistry. It was the application. It was the technician. It was the education that went along. It's a package because this is a process for that EVS technician to be involved in.
Yeah. That's a great point. Yeah, no, it is. And that's why, like I said, with the training, the use of the electrostatic technology in our healthcare partners was a really good thing for during the pandemic because, every EVS card had an electrostatic sprayer. And if they were going into a COVID room, patient, recovered and left and they needed to do a terminal clean, in order for them to feel safe, they would, obviously wear the N95 full with cartridges, everything, and go in and utilize the sprayer and let it sit for 3 minutes. And they'd be much more comfortable with then going in to start the terminal clean. So we called it spray yourself in, terminal clean, and then spray yourself out. So it was, the use of although a two-step product, it was really, and not only did it increase efficacy, but also staffing was a challenge during the pandemic and still remains. The introduction of electrostatic sprayers, because you could do much more with a lot less. So it's just a 1 second flyover of whatever surface it is. It's going to find it there, get the 4-minute claim, and that's disinfected. So
and I think the thing is that people need to understand too, Brian, is that just using the electrostatic sprayer by itself is not the whole thing. It is cleaning and removing as much of the bacterial, and I'm a big proponent of using very aggressive, high quality microfiber in that cleaning process to abrade the biofilm so that the chemistry can break in. Because what I've learned is no matter what the chemistry is, unless there is some kind of an agitation, unless there is some kind of a removal, that chemistry cannot break through all of that biofilm, and in some cases, never at all.
Dave, I want to take you on the road with me for my in-services. You are exactly right. I can't tell you how many times we go, how many facilities we go into, and they're just disinfecting. Mission critical to clean first. In fact, the guidelines to remain compliant with the guidelines, you must clean before you disinfect, but not always the case, but absolutely 100% truth, what you just said.
Okay, so then I'm going to hit you with my last one that I get into discussions and debates with. And I didn't tell you about this one before we got on the air here, Brian. So you're probably scratching your head going, oh, man, am I ready for this? I talked about this on my IAQ podcast earlier this morning, Brian, is that no matter what the chemistry is, why is it that we can't get it through our head that we need to rinse surfaces? I say all the time, you wouldn't go through the car wash and leave your car with soap on it. You wouldn't put your clothes on if they didn't go through the rinse cycle. You wouldn't eat your dishes if you didn't rinse them. Why is it that no matter what the chemistry is, we think we can leave it on a surface for people to touch?
You know what? It's the in healthcare, it's that it's an added step. Because you got to get, once you apply, you can't rinse or wipe off, obviously, to achieve the 4-minute dwell time. That the Joint Commission set a standard that we comply to. But yeah, I mean, there is once that dwell time's achieved, I could see our chemistry. You don't. I could see other chemistries because there's a residual left behind that it's needed to rinse in order to make it appeasable. But because of our neutral pH and everything, not the case. But yeah, no, I mean, I couldn't agree with you more.
I think this is the thing, and if you've listened to my other podcasts, folks, you've heard me talk about my experience 2 years ago. But one of the things I did, Brian, is I said housekeeping was not allowed in my room.
Yeah,
I was there for 10 days, and I said, and they looked at me and go, "Hey, folks, I don't need everything that's outside of this room. I don't catch an infection from my own self.
Yep.
As long as I could tell that the doctors and the nurses, the guy with the food tray, everybody, I mean, they come to realize that I wasn't going to be quite such an easy patient when it came to the, because of the thing you started the podcast with this afternoon, HAIs.
Yeah. Yeah, no, it's a big look, everybody, we're in this pandemic state now, obviously with COVID and everything. But, we've been talking, you've been in the business. I've been in infection prevention pretty much my whole career. I had a brief stint in neuro for a minute. And, but, what I've seen in infection prevention, it's just, the Ciorus, all that stuff is just rampant. And, it's challenging. It's challenging. And we get that a lot. A lot of patients, a lot of industry people like you and I, if we go in, we're super cognizant of it. It's just, I feel bad for the folks that go into these facilities that, aren't standardized and don't have a good plan in place. It's scary. And I totally, you said it, and I appreciate but unfortunately, that's what we see. People are aware and they're very afraid. But that's what having a good chemistry plan. These, a lot of hospitals are forward thinking. NYU, I can't say enough. I mean, aside from being world renowned, their director of VVS, director of building services, Dale Arnold. I mean, you cannot get more forward thinking. And on the university hospitals, they're just fantastic institutions that have a great program in place. And for all your listeners, obviously, if you get sick, just ask questions. You want to know what's going on, what are they doing? All these rates that we're speaking about. You heard me mention C. diff, Ciorus, infection rates. It's all. If you're really that concerned, I would log on. You can go onto the CDC. All this is public information. So if you want to choose your facility, a lot of these healthcare partners we work with are cognizant of that. So they're concerned, really big concern with their infection rate. So if you come ill and if you're that concerned, and I would obviously log on and check out what their infection rates are and ask questions what they're using to help keep you safe once you're in there. Like I said earlier, you're bringing the most infectious into an area where there's a lot of compromised people. And that's where bad things happen. But a good program like NYU, MD Anderson, a lot of our partners, Wakefield up in Massachusetts, a lot of them have such a great program. You should absolutely, feel safe. But do your due diligence before you go.
It sounds like we need to get some other people on podcast with us, Brian.
Yeah, I hear you.
I mean, I'd like to talk to some of those people that were in the trenches not only with you, but continue to do that. Speaking of such, folks, if you're watching the video cast right now, you can see the link that we have up here. If you're listening to the podcast, we're going to actually have the link in the podcast show notes, no matter what, so that you can go and read the whole study and the results. The thing that I think about is, where do we go from here? How many hospitals were involved and how quick is it going to be? And, that's where I've seen these studies before, and they're good and they have good, and then they die.
Yeah. Yeah. What the good thing is now with people being aware. And like I said, that the switch from being, once you get, because I don't know if there were, when hospitals, if you get sick in their hospital, they used to, bang you and bang the insurance company for a fortune. Now the onus is on them. So they're really cognizant of patient safety and really, really, So getting to these conversation, having this conversation with decision makers within healthcare has been really, really simple. And once they understand, and once they see the ease of how easy it is, and to be able to utilize what we do, and our chemistry, and how we train, how we take through our education, we take the onus off of them on education. We have skin in the game. There's a lot of I've seen, I've been in, like I said, I've been in infection prevention. When I first started, it was the Wild West. Nobody really cared, but I think people are starting to get really dialed in now, and really worried about not only their own health but also their patient safety scores. I think we're trending in the right direction. I really do. So we're happy to continue to do what we do. And helping as many people as we possibly can. So yeah, I think like I said, you get in these organizations and these big, national chains that are these healthcare chains, senior living, acute care, post-acute, all these facilities, they're really starting to understand what it is and trying to find a better one, and getting away from that quaternary ammonium, the class 1 carcinogenics, and just putting them in an environment, not only the patient safety, but their own employees can strive in and have good pride and understanding, and really save a lot of lives, because that's what it's all about.
Hey, I don't know if you know about it, but I have a trademark phrase, and you just happen to use some of it.
What's that?
I am a janitor, and I save lives.
Yeah, let me tell you. I mean, Dave, and I hope I know your listeners. That some probably have, because everybody knows a nurse, frontline workers, but the technicians that we work with, on the EVS side, not on the clinical side, our nurses, they're special people, but these EVS techs, that are even the transport techs, just forgotten folks that play such probably one of the most critical roles in these institutions, and they deserve all the praise in the world, and God bless their resolve for what these folks see. We've been through it. Hopefully it's in the rearview mirror now, but until the next something come out, we're currently dealing with a polio outbreak at a facility, and this monkeypox is new. Thankfully we have claims for both, so we're busy as beavers up here in the Northeast.
Yeah, well, you mentioned that, you've got that, hey, I got to tell you, Ebola hasn't left the face of the earth.
No way.
COVID's not going to. We've got Marburg as well, which, we've got monkeypox, and like you said, we've got all these bacterial infections and viruses and fungi are not going to go away. They are going to be here long after you and I are leaving this planet.
Oh yeah. And it's incredible. It's incredible.
We do our best.
Yeah. And look, that's all we can do. But, and we try to make it safer, and we try to save lives through education. Our efficacy, your listeners will see in the study, comparatively speaking to other chemistries that were tested with. I mean, the results are astounding. But now it's just that education component, and that's where we're going to really save the lives. The chemistry will work itself, but the education component, telling people why and where, and understand, that's when we can save. So they're not cross-contaminating things through our education. So it's a very big component.
And one of those key words is why. They have to understand why. That's my biggest word that I talk about all the time. If we don't understand why, this is, folks, why I went into asking Brian to explain all of these acronyms, so that you understand that this isn't just words that we use to make us sound good. This is real life and death situations that we're talking about. I always say that the EVS people in a hospital is one, but outside of that hospital, folks, if you're listening, you're just as important, because you're the one doing the job, keeping the people from going to the hospital if you do your job right. So when you hear all this information, please, folks, if you're not involved directly, get somebody that is directly involved in touch with this podcast, so that they can learn something about it.
Yeah.
We've shown you the website. We've shown you the study. Brian, is there any last things that you want to do before I close our session out for the afternoon?
Dave, I appreciate the time this afternoon so much. I mean, use me as a resource. You have my contact information. If anybody needs anything or has any question, my email's up there. Scribe me an email. I'll no doubt get back to you. I was just down, just was answering questions prior to getting on. I just had the opportunity, I was in Florida, Dave. I was at the Broward County Health Coalition. They invited me down, so I spoke down there. We have some great resources internally as it relates to clinical specialists. Like I said, Nicole Slasic's unbelievable. She's available. If anybody has any questions, concerns, anything, let me know. I'll reach out, or I'll get back to you, and we'll see what we can do. But yeah, like Dave, you said, you couldn't send it better. We spoke a lot about healthcare, but also, we do a lot of business with Delta Airlines and Marriott, and all those techs and EVS crews carry the same. They're keeping everybody safe. So, the takeaway today is, obviously our NYU study, but just trying to make everybody aware for a safer tomorrow.
Folks, we very much appreciate our sponsor, Gym Supply. You can find them at gymsupply.net. They've been providing cleaning supplies that help save lives since 1930, family-run operation here in Florida. So happy to be a part of that organization. There's two questions that I have before I close out here on this with you, Brian.
Yes, sir.
Where were you born?
I was born in a very, very small town just north of where I'm at today, called Brooklyn, New York. Yeah. I left.
And what is on your? Go ahead.
No, I'm the son of. My father. My father served the city of New York for many, many years, rather than a borough commander. We grew up in Brooklyn. I'm educated. I went to finished at St. Peter's University, then continued on coursework at Harvard Business School. So I'm a Northeast guy through and through.
So when you get down to Florida, that's kind of unusual.
Yeah, well, actually, you know what? Full disclosure, I spend any chance I can. I spend it on the West Coast of Naples. We have a house in Naples, Florida.
Oh, now see, now this gets to the second question I have for you.
Yes, sir.
What is on your personal bucket list for this year yet?
My personal bucket list. Great question. Personal, professionally, or?
No, personal, not professionally. Something for you, Brian, yourself. Something that you want to get done before the end of the year.
Before the end of the year, I'm going to get my personal best bluefin tuna. How's that?
So I'll bet you that house in Naples has got a boat close to it.
It does, but you know what? In the Gulf of Mexico, we only grouper fish. But out here where I am in New Jersey, we catch some big tuna. And I'm looking for I'm yet to get a 6-digit bluefin tuna. I've been trying for many years, but I'm confident this fall I'll get one. Now that I just said it in front of all these folks, Dave.
You know what? I was just watching a deal on the tuna people. I think it was on Discovery?
Discovery, yeah. Wicked tuna.
And 448-pound tuna?
Yeah.
Holy mama.
Yeah, that's a big tuna. And that's so, with all the stresses and what we see on a day-to-day, I'm very thankful. My brother Christian, we have a boat that we could actually get out to the tuna grounds and fish. So we have a blast doing it. But, I'm looking for that personal best this year.
So what is the personal best so far?
The biggest tuna, biggest bluefin, biggest yellowfin I've had to date is 78 pounds. The biggest bluefin tuna I've ever caught was 91. The biggest fish I ever caught, though, was a 765-pound swordfish off Isla Morada.
That had to be hours of stress.
4.5 hours to get into the boat.
Holy!
4.5 hours and a 6-pack of root beer.
Okay. Folks, this is the reason why we ask these questions. I love to find out things because, if you don't ask questions, you don't know. Yeah. One of the things that we talked about during this podcast today is you have to know what you're doing, the whys behind. So why did I ask these two questions? For a very simple reason. I know now where Brian started life. I do not know where that life has ended, because it hasn't. We know what he wants to get done this year, and that has to do with a big tuna. But whatever you do, folks, whatever journey that you're on, make sure that it is healthy, positive, and proactive. We'd like for you to share all of our podcasts that we have. We're in our 6th season. I think we're on episode like 50 something for this year. We don't talk about just cleaning. We talk about all kinds of things. Please like us and share. We're on Podbean. You'll find us at Beyond Clean with Ace. You'll also want to go to our YouTube channel, hundreds of videos there. Find us on YouTube at hashtag Academy of Clean. And yes, we're on Instagram, we're on Twitter, we're on TikTok, we're on Facebook. Go to our website, academyofcleaning.com, where you can find anything and everything that has to do about, well, what we do, why we do it, and please share it. Get the full experience with us. We do more than just talk on the podcast. We have all kinds of classes, as you heard us talk. Brian, I thank you for the information today. Welcome to come back. And hey, bring some of those other folks with you next time.
Promise, Mr. Thompson. Thank you so much for the opportunity. And if there's anything I could do for any of your listeners, my emails are there. Just reach out to me.
Thank you, folks. Till next time, we'll see you on the airwaves.
God bless.